Steve just covered this product service ID, which is the most important variable in PDE data. So in this segment, I'm going to discuss what kind of or how we can actually construct some of the medication utilization measures using this product service ID. And also we need a couple of other variables to create some measures capturing medication utilization. So what are those variables? And also I'm going to discuss a little bit in detail the benefit phase, which was mentioned a couple of times in the morning, in earlier segments. And then we also, I'm going to discuss two most commonly used measures that capture medication utilization. So we can construct both the MPR and PDC, medication position ratio and proportion of days covered. So we can construct these two measures using our PDE records. Right. So of course, the first variable that you would need to create some medication utilization, to examine medication utilization, is a product service ID. So this is NDC, right? So this is going to identify the drugs that's dispensed or the drugs prescribed and picked up at the pharmacy, and this captures NDC. And also we have a brand name variable and generic name variable in PDE data, but you have to really spell correctly if you're going to identify the drugs that you are interested in based on the names, brand name or generic name. Now, this question has come up a couple of times. So yes, oftentimes we are interested in examining therapeutic class, right? So you want to capture all the drugs that are used to treat diabetes, anti-diabetics or anti-hypertensions and statins. And it is really hard to capture or just the names or NDCs. So yes, I have used for my own studies. I did have used some database. I used the commercial database, mostly MedSpan. I'm not here to just to encourage you to use only MedSpan, but that was the most available. That's something that I was able to afford, right? So MedSpan, or you could go for a first data bank or Merton, and these database list therapeutic class and then all the indices that belong to that therapeutic class. And get if you use those database, oftentimes these databases have NDC variable, so you have to rename and then use the product service ID to link. And also this RxNome is not by FDA. Probably I should take out this FDA. So RxNome is a public resource where you can potentially identify all the NDCs that belongs to a class. Right. So what are then other variables? So there are two variables that you want to use. The first one is prescription service date, right? Service date, and this tells you when the prescription was filled. It's not really initiation. We actually don't know whether a beneficiary actually took the drug or initiated the drug use on that date, but this is simply when the prescription was filled at the pharmacy. And then we need some sort of a prescription amount, right? So that's in the medication studies, in drug studies, we usually use amount by days. So you can have this days supply variable in PDE data. So this is a descriptive data of this prescription days supply variable in 2021. And you can see the mean value is 51 days and median is 30 and mode is 90 days, which means that a lot of drugs were oftentimes the drugs were actually filled through mail order. So when beneficiaries fill drugs using mail order, usually they actually fill for 3 months, so 90 days. And in the pharmacy, probably physically it's usually 30 days. So this has actually changed over time. When we first started this workshop in early 2010s and then early 2012 or 2015, the mode used to be 30 days, but now it's 90 days. Probably it's cheaper, the lower cost sharing for mail order. And here about 36% of prescriptions had 30 days of supply and 42% has days of supply between 31 and 100 days. It's probably 90 days. Just a little note here, it's a very minor point, but you might actually find some records that have a value of 0. So here again, where you need to use your sort of discretion as a researcher. Hey, wait a second, what does it mean that the days of supply equals 0? It doesn't mean this. I mean, there is no data supplied, but then the claim is not claim. The event record is there, and we actually don't know whether it count this one or not, and how do we count when days equals 0, right? So and you could, I mean, depending on your study aims, you might actually want to exclude, or you might want to include because you are capturing, for example, uptake, but it's your discretion. But it's very, very small number of records. It's less than 0.01% of record had this value of 0, or even greater than 180 days. And even though if you see somewhere, oh, the prescription days of supply is 300 days, 365 days, it might be actually accurate and true value, but for those records, I would actually investigate a little bit more, print out or sort of prescription fields for that beneficiaries or around the different, similar names, and then see, probably a little bit verify whether you want to use this type of records or not. In summary, 3 variables, actually you need only, yes, the key variables in PDE data to study medication utilization. The first one is a product service ID, second one is a service date, and third one is data supply. So make sure that you actually really check these variables when you request PDE data. Again, PDE data is a variable by variable. You have to justify why you are requesting each specific variable. So these are variables, you have to say these are the key variables that we need to construct the medication utilization measures. Right. And then next, I'm going to move to the benefit phase variable. So benefit phase variable is, as we have discussed here, Medicare Part D has somewhat complicated, or the benefit scheme. So as patients spend their money on prescription drugs or Part D drugs, they go through different benefit phases, right? So these benefit phases is not really recorded in either claims or in any data. But this variable was constructed as derived by CCW, Chronic Condition Warehouse, where they prepare data files for researchers. So the way CCW does is that they actually accumulate all the drug spending starting from January 1st, right? So okay, January 1st, how much they spend, and then February how much, and then they accumulate this drug spending, and then up to that point where they actually fill that specific prescription, that event. And for that event, and then they compare, they actually compare this accumulated drug spending against the beneficiary's plan benefit structure. Oh, okay, if this beneficiary has spent up to this point about $3,000, which benefit phase does this event belong to? And that's how they derive this variable. So now you can think of, so when beneficiary fills a prescription, it could simply just a deductible phase, but sometimes, let's just suppose this beneficiary was at the deductible phase. However, this drug is really expensive. Let's just say it costs $20,000. Then by filling the prescription, right, for that event, that actually from the deductible, that actually jumps to the catastrophic phase, which means that prescription drug event could straddle more than one benefit phase just for one event. So that's why this benefit phase has 2 digits. So the first digit indicates a benefit phase at the start of a prescription fill, and the second digit would indicate the phase when the prescription is filled. So the example that I gave you from the deductible started with the deductible, but by filling the prescription, the beneficiary hit the catastrophic coverage, then the benefit phase variable would say DC. And this benefit phase for this event is DC. So I'm going to go through how they actually use the letters for each benefit phase. So this this is standard benefit. This graph shows, I got this one. This is actually how Part D program started. The benefit scheme of a Part D program started in 2006. So it began with the deductibles. We know that, and then in the so deductible means that beneficiaries pays everything, right? So it's just 100% out of pocket. And once they reach a certain spending, either in total spending or beneficiary truth or beneficiary out of pocket spending, they begin to pay 25 co-insurance. And this has been referred to as a initial coverage phase in earlier segment. Why is that? Because that's initial. This is where the first coverage actually starts. Now, once they actually spend more, they used to hit. Now this coverage gap is closed, but they used to hit this coverage gap, or also known as a donut hole. The donut hole or a coverage gap, that's what we usually call this benefit phase, but the official name of this phase is initial coverage limit. In other words, they hit the limit in terms of their coverage. So this is a deductible, and then there is an initial coverage limit, which is a donut hole or a coverage gap. And in between, this initial coverage phase is called pre-ICL, before hitting initial coverage limit. And then once you pass through this coverage gap, the beneficiaries eventually hit a catastrophic coverage. So the benefit phase variables takes this first digit of these benefit phase names, DPIC. And then if you remember, if you use this type of names, then you can actually identify easily, which benefit phase this specific event belongs to. Now, this simply shows that how the donut hole or the initial coverage phase has been closed over time. This is a 2023. We already looked at this one, and I also have a 2024 slide, but I just wanted to show here. Now, by 2023, donut hole has been already closed. So if you just follow beneficiary cost sharing, there is no difference between initial coverage phase or a pre-ICL phase and this ICL phase or donut hole phase. Beneficiaries are responsible for 25% co-insurance. So they don't feel that, they don't have any difference on the beneficiary side. However, still we follow the benefit phase as we originally started, Part D program started. Why? Why this beneficiary side, after deductible, it's just a 25% co-insurance until they hit the catastrophic coverage. But the reason we are distinguishing whether it's an initial coverage phase or a coverage gap phase is that because the rest of 75%, who pays the rest really depends. So initial coverage phase, this is a Part D plan phase, but in the donut hole phase, depending on generic or a brand name, the payers are different. If it's a brand name, 70% is covered by manufacturers and only 5% is covered by plans. But if generic drugs, plan pays 75%. Right, and then but until 2000, up to this 2023, there was a little bit of cost sharing during catastrophic coverage, but that was gone in 2024 this year because of Inflation Reduction Act. Now, I know this is here, yes. So you're looking at this one, you can see here, these are all the values of benefit phase variable. So you can see here, these are more just a non-available information. And DD is, it started with a deductible and it ends with a deductible. It's a deductible phase. DP is, the claim started with a deductible, but by filling that prescription, during that event, that actually hit the beneficiary hit the pre-ICL. So that is a DP. And DI is between deductible and ICL. And you can see your CC is just the all catastrophic coverage. IC is between ICL initial coverage limit and the catastrophic phases. And this is a distribution. So here you can see that majority of them are in PP. What's the PP? This is a pre-ICL, right? So about 45% of prescription event belonged to PP, pre-ICL period, and about 20% belonged to deductible, DD. And then from here, you can see, how many prescriptions were filled during catastrophic coverage phase. So probably if you add up that anything that has a C here, whether it's a first digit or a second digit, it's probably about 30%, about 10%, I'm sorry, 8% and less than 1%, less than 1%, probably about 10% of prescriptions were filled during the catastrophic coverage. So then now the question is here, so I'm covering this, but then for your own study, you have to think, do I really need a benefit phase variable? I mean, you have to again justify in your data request, PDE data request, do you need a benefit phase variable or not? So then let's think about a little bit, and then when we want to use a benefit phase and how can we use this benefit phase variable in the study? So very descriptive or simply we could ask, how many beneficiaries have actually reached the catastrophic coverage? And you can also see the overtime trend, right? It was only 10 or 20% in 2010, but now it's at 2020. About 30% beneficiaries reached the catastrophic coverage. And that's the information, right? Just showing some trend in terms of medication utilization or how much actually our beneficiaries pay. And also you can see that catastrophic coverage, I'm going to just set aside these 2024 issues. In 2023, how much actually beneficiaries paid during catastrophic coverage? It was only 5% co-insurance. So we would expect that beneficiaries' financial burden for drugs during this phase would be lower. However, over time, there have been a lot of costly drugs that became available. So like monthly cost would be easily actually exceed a couple of tens of $1,000. Then when you think about 5% co-insurance of those expensive drugs, that out-of-pocket spending could be really high, even during the catastrophic coverage. Actually, that types of research led to this IRA the component that, catastrophic coverage is not anymore catastrophic coverage. We have to reduce cost sharing during this coverage phase, and we finally removed co-insurance during this phase. And also you can see now it's moving forward, you can think about, wait a second, now beneficiaries don't have any cost sharing during catastrophic coverage. Do they change their medication use patterns once they hit the catastrophic coverage? That would be interesting, right? So let's suppose the beneficiaries hit catastrophic coverage in August or September. Now they have 3 months to go. So until January 1st the following year, you have 3 months that you have all no cost sharing. It's zero expense, right? Then they might have incentive to actually look for something, some medications that they need to take. Do I need medication now? It's free, right? So you may want to actually examine some changes in medication use patterns during this catastrophic coverage. And also, of course, now we have a lot of changes over time in benefit design through ACA or IRA, and you can actually answer all these questions before and after changes in benefit design. So if you are thinking about this type of questions, you want to include the benefit phase in your data request. I want to introduce a little bit on the, because next year we might have to actually change a little bit. So this is a preview of next year workshop. So this IRA introduced, not only they removed this co-insurance during catastrophic coverage, biggest change here is that they actually imposed 2,000 annual limit. So once you hit $2,000 out-of-pocket spending, now it's all medications are free. Right? So from 2025, there will be only 3 phases. So you have a deductible phase, and the initial coverage phase, it's just a 25% co-insurance. And then once you hit beneficiaries hit out-of-pocket spending $2,000, and just it moves to catastrophic coverage, and then out-of-pocket spending is zero. So I know it's really down the road, but when 2025 data come out, the benefit phase variable might actually change. Okay, So now that's with that, I'm going to actually discuss what kind of measures we can construct to examine medication utilization using our PDE data. Okay, so the first one, how do we measure medication utilization? So I know probably some of you have already about quarter of you said that you have used the Part D data, and that means that you must have constructed some medication utilization measures. So the first one that we could think of, what kind of measures? I would actually say uptake. So let me see. Right. So uh, I mentioned the MPR and PDC, but they both are adherence measures. But before adherence, one measure we can think of, one thing that we could study in our research is that that's beneficiary. Do beneficiaries actually use certain drugs, right? So medication uptake means that whether recommended medication is used or not. This is just a binary indicator, 0 or 1, right? But in order to use these uptake measures, oftentimes you are probably need to specify your sample with as some population with a specific condition, because that's how we can actually identify recommended medication, right? So if you have a diabetes, my study population is patient with a diabetes, and I want to know what percent of a patient are actually taking any anti-diabetic medication, right? So that's this is a one measure. However, in order to use this measure, you need some information on diagnosis. Do party data have diagnosis information? Yes or no? We don't, right? So PDE data do not include any diagnosis code. So which means that in order to identify your study population, you need part A and B data. It's for the people service, it's a people service claims. And if you're interested in the Medicare Advantage population, you need to request the MA encounter data. Here, I just want to give you another example here, because I want to introduce this example because we're going to look at this in exercise in the next segment. So Sovaldi, so this is one that I looked at in my own study. So Sovaldi is very innovative hepatitis C virus treatment. So before Sovaldi, so this drug was launched in December 2013, but before this drug, the medications that were used to treat hepatitis C drugs, it was somewhat very inconvenient to use from the beneficiary standpoint, right? So they required 48 weeks of a treatment period, and also it was I think it was a subcutaneous, so they have to actually inject the drugs. But Sovaldi came out, and it really has a very, very super nice novel characteristics, as this was oral medication, oral agent. So patient will simply take just one pill per day. That's convenient administration, and the treatment period was only 12 weeks. So this is finally that's really our the technology advances, right? So it's something worked now. But however, this drug came with a really high price tag. So the cost was initially, it was $1,000 per pill. So 12 weeks is 84 days, right? So that means that in order to complete the course of treatment using Sovaldi, it's going to cost $84,000. Right. So with this all this exciting and new and novel drug available, the question is really with this price, what percent of Hep C patient, HCV patient actually use Sovaldi, this new Hep C drugs? And that was my one of my research question. So that. This is just an example. That's something that you can measure. And these days we have a lot of innovative but yet expensive cancer drugs, or some how can I, some really serious conditions. But we have a new treatment, but you can examine using PDE data what's the really uptake and take up rates for those drugs. Right? So we will actually examine this using actually Part D data and exercise. Now, and then I'm going to move to the medication adherence measures. So medication adherence means that these measures captures the extent to which patient takes or does not take, if you're interested in non-adherence, a prescribed medication or according to a schedule. So a variety of measures can be constructed to capture medication adherence or non-adherence. Some measures focus on percent of the time the patient had prescriptions, or some measures may focus on percent of the time the patient did not have prescriptions. And also the measures can be defined in a different way based on what kind of time interval you are using. You may specify specific time period, or you may simply look at the repeated intervals. So the one of the commonly used measure is MPR. It's medication possession ratio, and this captures a proportion of days supplied during a given time period. I'm going to emphasize again and again, this captures only days supplied, and this is a possession. In other words, how many days did the patient actually had the drugs, the medications? So this can be defined in two different ways. The first definition is, okay, you first specify your time period, your follow-up period, and then you just get all the total numbers of days during the specified time period, and then your numerator becomes just the total prescription days supplied during that specified time period. And that's your one MPR measure. So before we move to the second measure, I'm going to look at how we can specify time period. So one way you can specify time period is just a fixed follow-up period. Let's suppose you are looking at statin adherence. So you say that, you know what, I'm going to actually follow a patient from the first prescription date. April 1st, for example. From that point, this is the first date that the beneficiaries picked up statin, and I'm going to follow them up for 1 year. Then it goes through the next year, March 31st in the following year. So everyone in this data has 1 year follow-up, which means the denominator is 365 days for everyone. Beneficiaries who start taking or filling prescriptions, statin prescription from July 1st, then you follow them up to June 30th in the following year, right? So for this measure, because the denominator is all the same across all the beneficiaries, then you could simply use actually the numerator only. But if you want to calculate MPR, you use just the days supply in your numerator, and it becomes MPR measure. Now, the second approach is that let's suppose you have only 1 year of data, which I had only 2007 data one time. So that was the first time that when I was learning about Part D data, I had only 2007 data. I cannot use this, fixed time follow-up period. So then in that case, what you could do is that, okay, I can follow up only to the end of my data or to the end of a follow-up period. So from the first field, that April 1st, 2007, but I have only 2007 data, so my study ends December 31st, 2007. So then you just count from the April 1st to the end of 2007, to the end of your follow-up period. Now, in this case, the denominator will be will be different across patient. And for a beneficiary who had first fill in July 1st, then you follow that beneficiary only from July 1st to the end of the year, December 31st, right? So then you calculate the number of days of that the specific to that patient and use it as a denominator. And during the specified period for each beneficiaries, what's the data supply? And then you use that as a numerator. That becomes this first measure, MPR. Just simply the days supplied in the numerator, and then the total number of days that you are following up. That's denominator. Now, this assumes that this MPR measure assumes that, okay, once you start filling with after first fill, what does this mean? When you follow up this patient up to the end of your evaluation period or a follow-up period, or at least just the 1 year or 365 days, that means that you assume that they are supposed to take that drug all through your evaluation period, right? Whether that's reasonable or not, it depends on what kind of drugs you're looking at or what your study aim is. But just sometimes you think that, oh, that's not really reasonable because some patient might develop some side effects of the medication, right? So then they have to stop. It's stopping is a really appropriate sort of action, and maybe physicians or the other, the providers may have told beneficiaries to discontinue their medication. So you really don't want to. So when you see that this beneficiary starting in April 1st, and then the last field date is only like, let's say July 1st, I really don't know why they actually stopped this, filling the medication, the prescription for this medication. So I'm going to simply just examine medication adherence during during these days between first and the last fill dates. That means that, when they actually fill the last time that medication, there may have been some reason that they have to actually had to discontinue. So I'm going to just stop there. Then you just get during this time intervals, you get the number of days. That's your denominator. And then in the numerator, so only during that time period, what's the time period in your denominator, you get the days of supply, but you have to subtract the prescription days supplied from the last fill, right? Because you stopped here, the last fill date was July 1st, but that has 30 days of supply, but you have to subtract that 30 days from the total prescription days supplied. And that's, I just call this one as MPR modified. So MPRM. And we will see in the example, does it really matter here? So let's look at this example. So how much does this denominator and the way we actually specify our the follow-up or time period matters. So for this one, this is a 1 year. So we followed up. This is from this one published paper. So this is just a 1 year follow-up period. And then, so simply if you're thinking about MPR, okay, my denominator is 365 days. So I'm going to simply, for this patient, the first fill date was here, and the last fill date was August 25th. And total days of supply during this time period that I'm following up, it was 118. So you simply divide the 118 by 365 days. Then its MPR is 0.32. So when you say the MPR is 0.32 means that, so you know that this is a non-adherence. And if this is like, the medications that treat chronic conditions, some medications are really lifelong treatment, like anti-diabetes or anti-hypertension or anti-hyperlipidemia. So if this was a statin, that might be reasonable. There is no reason, probably it's unlikely that they had to stop. It might be more likely to be non-adherence. Then this MPR measure is okay. But then you say that, well, still, I'm not quite sure why they actually stopped here. So I'm going to actually use the days between this first fill date, April 27th, and August 25th. And that was going to be my the denominator. Then you simply add up these days in interval from the first fill to the last fill. No. Not here. I'm sorry. This is data supplied, but between this April 27th to August 25th, and that becomes your denominator. And then you add up this days supplied from here, and then you. I'm messing up. Sorry, this is the days supplied, and this is days interval. So you have to add this days in interval in the for denominator. So the sum of this 4 rows, days and interval will be your denominator. And then this days supplies, you add this up and then you subtract this 10, which is the data supply from the last field, from this 118 becomes your numerator. And then you get the MPR modified as 0.9. And this is a really good adherence, right? So so the bottom line here is it really depends on what you want to measure and what is really reasonable in terms of the specifying your follow-up period. And then that's going to determine whether you want to use MPR or MPRM. Or another approach is, and a lot of times in my own study, that when I looked at more chronic condition medications, MPR and MPRM, they are not that much different. This is a little bit exaggerated example. So you may want to actually use both measures as a sensitivity checks. Right. So now one issue with the MPR here is that this is oversupply, and this is some what is oversupply or overlapping supply, and this is supply in excess of what's appropriate or required. So in this case, when there is overlapping days of supply, the MPR will be greater than 1. Wait a second. What does this mean? MPR is greater than 1. I mean, wouldn't you? I mean, you are supposed to take, have 100 days of supply because you follow them up for 100 days only. However, your numerator is, let's say, 200 days or 115 days. What does this mean? They would not have taken all those medications, right? They means the patient, right? So let's look at this example. What a little bit more clearly what kind of problems it actually causes, overlapping days of supply. So for these beneficiaries, wow, so the first field date is June 19th. So days supply is 21. So in 21 day, 1 days later, this patient came back, and so days in interval and days supply, days are equal, which is good. So this patient came back on July 10th, and then got the 35 days of supply, good. And then came back again, and 35 days later, good. Now, August 14th, the patient filled only 21 days of medication. However, the patient came back 30 days later. Means that this beneficiary had 9 days of missing, right? So at least, let's suppose, we don't know, but let's suppose all these medication were taken by this patient, but still here, the beneficiary, this patient, clearly missed the 9 days of medication, right? But when you go down here in October 13th, this patient picked up 35 days of medication, right? But he or she came back 30 days later. Oh, this means that the patient likely must have, or likely have, 5 days of medication in sort of excess, right? In excess. They have 5 days of medication they didn't use when they came back on November 13th. But if you use calculator, we don't follow day by day, field by field when we calculate the MPR. We just collapse, right? We just get the sums. So here, when you sum up all the data supply for your numerator of an MPR measure, what happens is that these 5 days of excess medications, which they have this 5 days of medications, which that the beneficiary had in October. But in the MPR calculation, these 5 days were filled towards some missing days in August. Does it make sense? So because we are not really following the field by field, anything that has overlapping or excess days of a supply, it's actually they are used to fill the missing days or non-adherence for the earlier date. That's not good, right? Because there is no way they could have used this 5 days of medication for August, right? And this is another, the okay case is here. So in November 13th, so let's suppose that they filled 15 days of medications, but then the study ends in November 30th. So they had 17 days to take the medications. So these 5 days of extra medications that they had in October, some of the 2 days of medications were used in November. That's good. It's used only for prospectively, right? Because it's something that had in October can be used in November, but the other one that's used for the August, that's not reasonable, right? So that is an oversupply or overlapping days of supply issue. That's an issue associated with the MPR. So that's why people came up with this measure that's a proportion of days covered. It's more commonly used. It used to be, MPR used to be the most commonly used measure, but over time, I think most studies have begun to use more days, a proportion of days covered. So this one is again that's what MPR is in a sense, right? MPR is, I said, it's a possession days, right? So possession or supply. So that means that we're going to be sort of ignorant. We are not going to care about how they were actually covered or not. But when you look at when it says that days are covered, which means that actually covered is not really taken. It's not the same as taken, but if we assume that the potentially those were covered were taken by patient, we could think, okay, we should apply oversupply portions only prospectively. In other words, if there is any, you detect any oversupply, adjust those, use those the oversupply portions for the missing days that comes after that days. So if you see graphs here, okay, so this is the first field date is April 21st, 2005 here, just a claim one. And you can see here there is some non-adherence, missing days here, right? So this is a non-adherence in earlier days. And then this was exact, but in the claim 4, in the fourth field, prescription field, there was a little bit of oversupply. So in July 7th, this beneficiary filled how many days? Days between 78 and 10. How many days is this? About 28 days. So they filled the 28 days or 20, is it right? Yes. Let's say 28 days of supply here now. And then this beneficiary came back a little bit earlier, right? Before he or she consumed all the medications filled during this third fill. It wasn't fourth, right? Third fill. Now for this portion, this beneficiary cannot use this excess supply for missing days that happened in early days, right? In May or June. So what the PDC measure is that, okay, I'm going to push this one so that they can start the date, this drug only from August 6th. So even though this beneficiary came back on July 30th before consume all the drugs, and they came back July 3rd, but I'm going to say that this July 1st, the start date is August 6th, so that they can use this. So they are pushing to use up this oversupply portion so that it doesn't go back to the earlier days, right? So in that way, you don't have you do not use this oversupply portion unreasonably just to improve the increase the ratio, right? So this is what the program does. You can find the SES program that lets you calculate the PDC, and then the program actually, whenever they detect, they actually go through field by field. And then when they, whenever they identify over excess, they actually pushes the start date for the following claims. Only the after they actually consumed all this oversupply portion, and that's PDC measure. Right. So a couple of final thoughts here that so you can measure a variety of the medication utilization measures based on PDE data, but it's what you should remember is this is acquisition of a medication but not consumption. This is somewhat inherent inherent limitation of administrative data. We cannot actually follow the consumption of medications. And also, if you are really interested in the timing, so some drugs are supposed to take in the morning and when you wake up. So if you consider timing of taking medication as also part of adherence or following the recommendation, but we cannot do that using our PDE data. And also PDE data alone does not tell us condition for which the medication is prescribed. However, administrative data have their own strength as well. So using this PDE data, now we have a really national estimate. If you begin to follow patient, you're really observing patient whether they take drugs or not, when they take the drugs, and those are, you can do that really small sample size. It really limits generalizability. But using PDE data or administrative data, you can get the national estimate, and having this large data can allows you to do more subgroup analysis. So with a small sample, you have always a very too small sample for a specific population, even race groups or some age groups. And also with this, now we have now more than 15 or 20, yeah, 18 years of data. So this the PD data allows us to do really long-term follow-up studies.